Hi, I'm Mitch, first year fellow. I'm going to talk about fecal microbiota transplant. Lily asked me last week, why do I need to do this topic while you guys are eating dinner? But we just had a new case in VA. It's not a new case for me, it's a new case for VA itself. So I think it is like hot topic, so that's why I choose this topic. So I'll start with the case. 71-year-old male with history of T7 polyplasia since 1984, recurrent UTI, recurrent C. diff colitis. Basically, ID was consulted for the recurrent C. diff management. The patient had a history of C. diff colitis in January 2013, treated with oral vancomycin therapy for 14 days because the patient had a reaction to metronidazole. The symptom recurred 1 month after the completion of the treatment. At the time, he was also treated with same regimen. And the second recurrence in March 2013, ID was consulted in VA. Joe was consultant at the time. He recommended vancomycin tapering regimen, and he talked about fecal microbiota transplant with the patient, based on the note. But fortunately, the patient seems to have been improving with vancomycin tapering regimen, but the patient kept asking to Dr. Gump whether he can get fecal microbiota transplant in VA or not, and we decided to perform fecal microbiota transplant in VA. So I'm going to talk about C. diff colitis incidence really briefly. So here is the incidence of the C. diff colitis. It's 1993. The incidence was 85,000. But in 2001, it increased to 148,000. And from 2001 to 2005, it increased more. It's 300,000. So the incidence of the C. diff colitis has been increasing over decades. The reason for the increase is possibly from emergence of newer, more virulent, and more antibiotics-resistant strain called NAP1 B1 027. Also, most C. diff infection is known to be caused among the healthcare facility, but also increase in the community setting is reported. Here is the prevalence of the B1 NAP1 027 strain. Is a report from CDC. In 2007, pretty much everywhere in the United States, includes Florida. And also another reason of the increase of the incidence is relapse, as we know. Relapse rate of the C. diff colitis occur approximately 10 to 25%, and up to 65% of patients who experience one recurrence will have subsequent recurrence after antibiotic therapy is stopped. So if the patient has already one recurrence, then it's higher chance to have more. And the basic pathophysiology of recurrent C. diff is not completely understood, but there is a hypothesis of the recurrence. As we know, C. diff spores are resistant to antibiotics, and they can germinate back into vegetative form after treatment of antibiotics. Also, residual normal intestinal microbiota cannot restrain the infection, and C. diff bacteria proliferate and produce toxin. Some patients may become reinfected with different strains. In one report, say 33% had a different strain. So not only the recurrence, but also reinfection is a problem of the C. diff infection. And then treatment, in terms of treatment, here is a guideline of the IDSA 2010, 3 years ago. I would say it's relatively new. So the first recurrence, meaning second episode of the C. diff colitis, basically the recommendation is same regimen for the initial episode. This is A2 recommendation. But beyond the first recurrence, avoid using repeated metronidazole because of the neurotoxicity. For the second recurrence, they recommend vancomycin tapering regimen, like Joe mentioned to the patient. But more than 2 recurrence, it's surprising. There's no recommendation from IDSA in 2010, 3 years ago. But they didn't recommend anything, but there is an option for the C. diff, management of C. diff infection. One is rifaximin chaser, as we know, but it's reporting CID 2007, uncontrolled case series of the patient with multiple recurrent C. diff infection, at least more than 4. They treated with vancomycin PO for 14 days, followed by rifaximin for 14 days. 7 out of 8 patients was cured after the completion of this regimen. But the caution in this article is like, even in the article, they warned us C. diff can get resistant even during the treatment with rifaximin. So resistance is a problem with the rifaximin chaser. Another option is fidaxomicin, as we know. It's a macrocyclic antibiotics. It is same as, I think it's macrolide, right? And it's more active in vitro against C. diff, including NAP1, B1, 027, and has a little activity for inhibiting other bowel flora. It achieves very high fecal concentration with minimal systemic absorption. There is a randomized control trial for the fidaxomicin, 178 patients with 1 prior episode of C. diff infection. It's divided into 2 groups, fidaxomicin group versus vancomycin 125 milligram QID for 10 days. 88 patients were assigned to fidaxomicin group, and 90 patients were assigned to vancomycin group. Basically, the cure rate is same. 90% is cured at the time of the completion of the treatment. But the thing is recurrence at day 28 here. Fidaxomicin group was 19.7% recurrence versus vancomycin was 35.5% recurrence. So the cure rate of the fidaxomicin is 85%, so 80%, and the vancomycin PO group is like 65% at day 28. So it's fidaxomicin suppressed the recurrence compared with vancomycin oral group. In terms of the use of the probiotics, IDSA does not recommend use of the probiotics because of the risk of the fungemia among the immunocompromised patient and the patient with central venous catheter. So we should avoid using probiotics for the critically ill patients. Now, I'm going to talk about fecal microbiota transplant. This is an option for the treatment of the recurrent C. diff colitis as well. So human gut microbiota is estimated consists as many as 100 to 1,200 bacteria species and at least 10 to 14 power bacteria. So the role of the microbiota is synthesis of vitamins and fermentation of dietary carbohydrates, metabolism of bile, host hormones, and the competitive exclusion of pathogen. So they are doing a lot of things in the gut. The rationale of the fecal microbiota transplant is recurrent C. diff colitis is associated with decrease in fecal microbial diversity, deficient in Bacteroides and Firmicute, I can't pronounce well, both of which generally dominate within gut microbiota. So the first case of fecal microbiota transplant for C. diff infection was reported in 1983. It's 30 years ago. I was 6 years old. Dr. Ella was junior high school. It's a long time ago. It's reported from Sweden in 1983. And it's reported in Lancet. It's kind of big journal. And then treatment was successful for the 65-year-old female with prompt and complete resolution of bowel function by rectal infusion of feces. So it was successful. I didn't know like this long time ago. As the efficacy of the fecal microbiota transplant, observational and systematic review have shown efficacy of the fecal microbiota transplant, and cure rate is ranging from 81 to 94% in patients with recurrent disease. Pretty high cure rate. And the time to response within 24 hours to 12 days. And in one study with variable follow-up ranging from 3 weeks to 8 years, pretty much the response appeared to be durable. Here's a recent article from Netherlands, New England Journal of Medicine, January 2013, this year. So they did a randomized control trial for the patient with relapse of C. diff colitis after at least one course of antibiotic therapy. So meaning like first recurrence is the inclusion criteria of this study. They divided to 3 groups. One is vancomycin 500 milligram PO-QID for 4 days, followed by bowel lavage and fecal transplant. And also vancomycin regimen. This is like just PO, 500 milligram QID for 14 days. Also vancomycin PO plus bowel lavage. They compared like primary endpoint is resolution of diarrhea without relapse after 10 weeks. This is small, open-labeled randomized control trial. 43 patients underwent randomization. 17 patients were assigned to receive fecal transplant, and 13 patients were assigned to receive vancomycin, just PO. And 13 patients were assigned to receive vancomycin and bowel lavage. And then here is the result of the study. So the first infusion of the donor feces, the cure rate is 81%. If the patient had a recurrence of the symptom, they transplant one more time from the different donor, and the cure rate increased to 93.8%. Compared with this group, vancomycin oral had only 30% of the cure rate, so 70% had a recurrence. And interestingly, vancomycin with bowel lavage even lower rate, 23% cure rate. So here is a recent article from New England Journal of Medicine. Based on the clinical gastroenterology and hepatology protocol, current indication of the recurrent C. diff infection, current indication of the fecal microbiota transplant is at least 3 episodes of mild to moderate C. diff infection and failure of 6 to 8 week taper with vancomycin with or without an alternative antibiotics, and at least 2 episodes of severe C. diff infection resulting in hospitalization and associated severe morbidity, and moderate C. diff infection not responding, standard therapy for at least a week. Severe with no response to standard therapy after 48 hours. So basically, the number of the recurrence and the severity is a matter for the indication of the fecal transplant.
Which group is saying this? GI group.
Yes, this is just a protocol. I don't know. This is 2011. I think it's changing after the article, and even the protocol is different from this article. So I'm going to mention about that later. So as a route of the administration, up until 1989, retention enema had been the most common technique. But the fecal infusion via duodenal tube started in 1991, and it's more common nowadays. Rectal tube placement started in 1994, and via colonoscopy started in 1998. But there are no clear superiority of one method over another. As a safety standpoint, FMT seems to be pretty safe at this point. Major complications have not been reported in published series. Some risk with use of NG tube and colonoscopy, like general risk. As an adverse effect is transient and mild abdominal gurgling, gas, and noise. They didn't talk about PTSD or mental issue at all in this protocol. At the exclusion of the donor, they're going to talk about the risk of they talked about the risk of the infection. Basically, non-HIV, hepatitis is excluded. Also, any pathogen causing diarrhea is also excluded, should be excluded. And from the GI comorbidity standpoint, history of inflammatory bowel disease, also irritable bowel syndrome, and gastrointestinal malignancy should be excluded from the donor selection. And the last exclusion criteria is factors that can affect the composition of GI flora. Antibiotics within preceding 3 months, and a major immunosuppressive medication, and systemic anti-neoplastic, like a chemo, systemic chemo, should be excluded from the donor selection. In the donor selection. So to exclude these things, we should order a stool testing, C. diff toxin, routine bacterial culture, Giardia antigen, Cryptosporidium, AFB, O1P, and H. pylori. For the serum testing, we should check hepatitis and HIV and RPR, like a syphilis workup. If all negative, then preparation for the donor. We can consider the use of gentle osmotic laxative the night before the procedure to get the good sample. And avoidance and avoidance of any foods to which recipient may be allergic for 5 days prior to the procedure. As a recipient preparation, first one is optional, large volume bowel prep, and the second is loperamide. And if FMT is to be delivered by energy tube to suppress the stomach acid, give PPI the night before and the morning of the procedure. This is what we did. As a handling, use as soon as possible after passage, but certainly within 24 hours, and preferably within 6 hours. And the use of the food if possible. I don't need to mention about universal precaution. We need to wear, obviously, gloves to handle the stool specimen. What? This one, Walmart. Actually, we get from Target.
I thought that you just go get the little shop that they have on the second floor.
Linda mentioned to me they bought from Target. As a FMT preparation, use of either normal saline for IV or 4% milk is preferred to dilute the stool sample. A conventional household blender should be used. And the stool should be filtered to remove as much particulate matter as possible. Like using coffee filter, gauze, or urine stone strainers. In VA, they tried coffee filter, but it didn't work. Nothing come out. So they changed to gauze, and they get the stool slurry. The ideal volume for installation has not been established yet. However, the smaller volume, 25 to 550 cc from above, but the larger volume from below. But this protocol mentioned like just small, like 25 to 50 cc. But the article that I mentioned in New England Journal used like 500 cc of the stool slurry.
From above?
From above.
Oh my God.
Yes. Actually, we used 500 cc and infuse slowly, like 10 cc per hour. The recommendation is less than 50 cc per hour.
How do you infuse it slowly? You put it in
Like a
feeding tube
yes,
thing?
yes, feeding tube. That's what we did. And
how do you package it in the bag like a feeding tube thing?
yes, it looks like
Looks like chippy.
Cappuccino. It does look like cappuccino. That's what the patient mentioned to us. And the picture is yes, this is what the patient mentioned to us. So again, we can use enema, energy tube, rectal tube, or colonoscopy, either way, to give stool to the patient. As an evaluation of the success, for the primary endpoint, resolution of the symptom, and the secondary endpoint is absence of relapse within 8 weeks of fecal microbiota transplant. Here is the cost of the treatment. So vancomycin tapering regimen costs like $2,000 to $2,400 when we use capsule. But in the hospital setting, it's cheaper because we use IV vancomycin for with solution. So it's obviously cheaper. But rifaximin chaser with vancomycin PO for 14 days, it costs $2,200 when we use capsule. And the fidaxomicin is even higher, $3,500 for 10-day course of the treatment. But fecal microbiota transplant, it's not free, but it costs like $480 for vancomycin capsule for 4 days. And then testing for donor is $365.
It costs more than $365
Plus the blender.
Plus the blender. The blender.
Right. Blender, PPI.
Really? HIV, hepatitis, and all that testing, and it's only
I calculated. In this protocol, in the journal of this protocol, they mentioned like the cost, how much it cost for the like stool testing, HIV, hepatitis.
Well, my understanding and reading some of the people's experiences, reimbursement is a problem, though. My understanding is for this, where you can get reimbursed for treatments, like giving a medication. Reimbursement for fecal microbiota transplantation is not yet hit mainstream. I'm not sure what code you would actually use. It doesn't have a code, but does it have a funding associated with that code?
So what happened to the blender?
What happened to the blender? It's disposable.
The cheapest blender you
Yes.
can find.
So just threw it away. And then back to the case. As Joe recommended to the patient, he had a fecal microbiota transplant, and it was successful. He was discharged to home 3 days after transplant, and then at this point, no signs of recurrence. This is just 2 weeks, so we cannot tell at this point, but still successful at this point. So as a take-home message, Stu might be our friend. What? That's it. Thank you.
We can make you just all we want, but how much of a disruption or difficulty was this to actually get this done?